Dr. Brij Mohan from Kanpur, India, and we are here at EASD 2022, Stockholm. We just finished the fourth day of this convention of largest all over the world. Attendance was more than 7,500 delegates personally present here and more than 3,000 delegates online present here. So total attendance was more than 10,000 delegates. Now we just finished a very, very important session for all the doctors all over the world. That was ADA EASD Consensus Statement 2022, which was just finished. And I'll tell you some highlights of that. So the first and foremost is that we must try and find out that each patient is different. Individualization of therapy is very, very important. We must look at the social background of the patient, the comorbidities, cardio-renal impact. The cost of therapy is to be taken into the consideration, especially in low-income group company or the developing countries. And we must try to focus on blood sugar, that is the glycemia management, as well as at the same time look at the various cardio-renal benefits of recently introduced drugs. Now the important thing is that these drugs of the class, namely GLP-1 RA, injectable one, which have got proven benefit, and then the SGLT2 inhibitors, the oral drugs to be taken once a day with proven cardio-renal benefits are to be used in combination with metformin. Important thing is we must try to protect organs of the patient. We look into the weight of the patient. We look into the social background of the patient. That means we must focus on individualization of therapy. So one major shift is made this year is about organ protection, about weight management. We need to avoid hypoglycemia, so we must start with metformin, which remains the baseline therapy in majority but not all of the patient, and try to combine it with either GLP-1 RA or SGLT2 inhibitor or maybe glitazones, that is TZD, so as to reduce the possibility of hypoglycemia. This needs to be done even in younger patients. We have enough evidence as of now that combination therapy works better as compared to monotherapy. So start early with combination, avoid inertia. We must escalate the therapy as early as possible so as to reach the glycemic goals faster, at the same time avoiding hypoglycemia and giving patient benefit of organ protection. So GLP-1 RA and SGLT2 inhibitors stand out in that way, that a combination of metformin plus GLP-1 RA or a combination of metformin plus SGLT2 inhibitor in majority of patients will avoid hypoglycemia, will reduce weight. Weight focus has been very, very important. We have enough evidence as of now that GLP-1 RA are better at HbA1c reduction as compared to SGLT2 inhibitor. They are better at weight reduction also. And there is a class of agent recently introduced in US, approved in US by US FDA, that is dual agonist. The GIP plus GLP-1 receptor agonist, namely tirzepatide, which gives excellent weight reduction, as good as metabolic surgery. That should be used in the patient if you want to lose weight faster, if you want to reduce HbA1c faster. GLP-1 RA stand out over and above SGLT2 inhibitor. Now, SGLT2 inhibitor needs special mention because they are oral, they are relatively affordable in our country like India. Now, dapagliflozin is off patent, so it is far more economical as it used to be. We must try and use combination therapy in younger patient, in high risk patient, emphasizing that all patients above 55 years are high risk, all patients with diabetes, with obesity, those who are smoker, those who are having evidence of albuminuria, with reduced EGFR, with smoking habit should be prioritized, and they should be given combination therapy to begin with. So it is important that we identify these patients early in the course of disease, maybe at the time of diagnosis. That is all from Stockholm, EASD 2022. See you next time. Thank you.